Good afternoon, everybody. We will be beginning at about 1 p.m. I just want to let everyone know that this presentation is in listen-only mode, and on the right-hand side, you will see a control panel. At the end of today's presentation, you'll be able to type in your questions or comments on the right-hand side under questions. In addition, the handouts are also on the right-hand side for you to download. Once again, today's presentation will be in listen-only mode. For questions, we will be taking them at the end of the presentation, and you could type them in on the right-hand side. Handouts also will be found on the right-hand side in the control panel. Again, we will be in listen-only mode, and we'll be beginning at 1 p.m. Thank you. Good afternoon, everybody, and welcome to Care Connection, the free live webinar, the second Thursday of each month, and we also have our special edition, which is today. Before we begin, I want to let everyone know that today's presentation will be in listen-only mode. On the right-hand side, you will see a control panel. On that control panel, you will be able to type in your questions or comments, again on the right-hand side under questions. In addition, we have handouts from today's presentation, including the PDF of today's PowerPoint presentation on the right-hand side under handouts. Today's presentation will be on the impacts and tips for dementia-related sleep disturbances. We have a very special guest presenter, Dr. Nancy Hodgson. She's an associate professor in the Department of Biobehavioral Health and Anthony Buvadis Term Chair in Gerontology at the University of Pennsylvania School of Nursing. A nationally recognized nurse researcher, Dr. Hodgson's career has been focused on the development, testing, and dissemination of person-centered and family-centered interventions for persons living with dementia. As a clinician and educator, Dr. Hodgson seeks out innovative ways to foster academic community partnership by linking research and practice in order to move evidence-based findings into dementia care practice. She's a fellow in the American Academy of Nursing and the Gerontological Society of America. Dr. Hodgson, please now begin your presentation.
Thank you so much. I'm so honored to be here today to talk about this very important topic. Sleep problems are very common in individuals with dementia, and I'm sure is the reason for you phoning in today. They're also a very common source of tension for family caregivers because when your loved one isn't sleeping well, certainly you're not sleeping well. 40% of all individuals living with dementia have some sort of sleep disruption, and it's often reported among family caregivers to be the main reason that they need to decide to put their loved one in an institution because they're just utterly exhausted. We also know that sleep disruption is not good for individuals with dementia. Certainly, you know, is when you have disrupted sleep, you're more prone to emotional instability and irritability. Also, perhaps you have trouble concentrating. So these are all also worsened in individuals living with dementia. And so the goal for today, I actually have 4 goals for the presentation today. The first I want to talk about is why sleep is so important. What are the factors associated with sleep and the different stages, because each stage of sleep actually has a different property, and it's helpful to understand that when we understand what's happening in brains of individuals living with dementia around sleep. We'll then talk about 4 of the most common sleep disturbances that are most prevalent and across the population, but exceedingly prevalent in people living with dementia. So we'll talk about it both in terms of common sleep as we get older, common sleep problems as we get older, but also specifically for persons with dementia. And then finally, and most importantly, we're going to talk about strategies that have shown in research to improve sleep in people living with dementia. So first, I want to talk about sleep and the properties of sleep. I should say that we've also allotted plenty of time at the end of the call to take your questions. So please, make notes and feel free to ask questions along the way. First, we're going to talk about the properties of sleep. Experts define it as this reversible state of disengagement and unresponsiveness in our environment. We know certainly that in all living species, they have some stage of sleep. It's natural. We need it. It's also a time when we have a decreased consciousness. Our muscles relax. We lay down, so we're in a horizontal position. That's kind of important too. And we're not moving, and our eyes are closed. So thinking about those properties of sleep, most of us would say it's a time for restoration. And certainly some of the early stages of sleep are about restoring our brain, letting it rest and letting our body rest from all the information that we've obtained over the day and all the sensory and all kinds of information that our brain takes in over the day. The second property of sleep that was around learning and memory, and there's actually a period of time during our REM sleep, REM is REM, and it stands for rapid eye movement. When we look at our brain's activity during REM sleep, it's as active as it is when we're awake. There's lots of synaptic activities taking place then, and that's a time when memories are being formed and learning is happening. And it's this stage of sleep that is particularly disrupted in individuals living with dementia. And in fact, we have some new knowledge to suggest that these sleep changes precede the dementia itself or may contribute to some dementia factors and memory factors that happen in dementia. And we'll get into that in a second. But sleep is certainly a very important, has very important properties that are essential to our survival. And disrupted sleep is certainly associated with all kinds of poor outcomes. So let's talk about sleep stages for a second, because again, they all have very different properties. So stage 1 sleep is is sort of like when you're daydreaming, but perhaps with your eyes closed. And in fact, we see a lot of stage 1 sleep in people with dementia. You may notice this when you often in your loved one, or when you perhaps visit nursing homes, you see individuals sitting around. They're really not participating in their environment. They don't even seem to be perhaps even engaged with their environment. And when we look at their EEGs and we monitor their brain activity, it looks like they're in stage 1 sleep. This is a stage of sleep you can be aroused from, but we need to move through stage 1 sleep in order to get to the better stages of sleep. So there's not a lot of information about what happens during stage 1 sleep, other than it's essential to move through stage 1 sleep to get on to the deeper stages of sleep that are important. So stage 2 sleep happens after stage 1 sleep, and this is a very restorative stage of sleep. It's a stable stage of sleep. We move on from stage 2 sleep to stage 3 and 4. We now combine those stages and we just call them slow wave sleep. This, when we look at the brains, is characterized by these very deep waves of sleep. This is the most important stages of sleep to restore our energy. When you're in deep wave sleep like this, you're very difficult to wake up. If you think about new parents who have a baby and the baby is waking perhaps every 20 minutes, new parents often are encouraged to sleep when their baby is sleeping, but they often still complain that they're not getting good restorative sleep, or that they don't feel very restored even though they may be napping lightly. It's because they're only actually getting to stage 1 sleep and perhaps a little bit of stage 2, but they're not sleeping long enough in order to get down to those deep wave sleep. And that's why when you're waking quite a lot during the night, and perhaps you are too with your loved one, you may not feel like you're really getting to that deep restorative sleep. After those stages of sleep, we then move into REM sleep. There's a figure here on the slide that you can see. It shows the boxes that move from stage 1 down to stage 4, and then there's this period of black sleep. That is the period of sleep we would call REM sleep. And it's interspersed throughout the night in chunks of time that generally are about 30 to 40 minutes in duration, depending on the dreams that we're having. This is the stage of sleep, again, where the brain's very active, and this is when a lot of learning and memory is taking place. So this looks like a typical night of sleep. We move in and out of these, we go in and out of these stages of sleep in 90-minute cycles, up and down. Sometimes we stay in light sleep, then we go down into deep sleep, but we cycle in and out of these stages of sleep throughout the course of the night. And that would be a healthy stage and a healthy, good night of sleep. Why do we sleep, and what is the thing that tells our brain that we need sleep? Well, if you look at this picture, you'll see a little red dot in the center of the brain. That little red dot is called the suprachiasmatic nucleus, or the SCN. That's actually the clock region of our brain. And it is driven by the sun. We are creatures that move by the sun. We call that circadian, in that when the daylight occurs, we are alert and aroused and awake. And when the sun sets, we should feel lethargic and tired. There's several things that are happening. First, our eye is taking in that light and cueing the clock region of our brain. There's also other regions of the brain that control our hormones and our body temperature. So those three things come together to influence our sleep. You'll notice that perhaps in the daytime, your body temperature goes up. In the morning, it'll be cool and it'll rise throughout the day. And then in the evening time, it's often a good rule of thumb to lower the temperature in our sleeping quarters. Often below 70 degrees is suggested. And that's because it helps our body to cool down, and we need to be cooled down when we sleep. Certainly when you have a fever, or if you're going through menopause and you have hot flashes, you know that it is very hard to sleep during those times when you have hot temperature. So certainly we want a cool environment, and that's one suggestion for helping people sleep. We want a dark room, and we want to dim the lights in our environment as the sun is setting. Many environments where people are living often may not have a lot of good bright light, so we want to also have good bright light in the day. All of these are messages that tell the brain that it's time to be awake or time to sleep, and they're very important. The other is hormones. So our stress hormones peak during the daytime and drop during the evening. However, if you're very stressed, and people with dementia often have a lower threshold for stress, they may need to have some relaxation in the evening to help their stress hormones go down. When your stress hormones are going down in the evening, it's also the time that a hormone called melatonin is increasing, and that's also driven by our clock region of our brain. Melatonin is something you can buy over the counter, and it's actually quite useful in people with dementia in very little doses. And so we'll talk about melatonin in a little bit. But when we take a little dose of melatonin, and perhaps if you've ever done international travel, you've been instructed to take some melatonin to help keep your clock region on target. It is a useful over-the-counter medication. Because it's over-the-counter, unfortunately, we don't have a lot of good control over the doses that people are taking. And so you have to be a little bit more careful, and also making sure you talk to your pharmacist about getting a good product if you do buy melatonin. But these are the biological factors that influence our sleep and are disrupted in individuals living with dementia. Their body temperature can be dysregulated because of changes going on in the brain. Their hormones being expressed, especially their stress hormones, can be also altered, and their stress hormones can be higher. And they may have not the right amount of light in their environment to help drive their brain and tell their brain that it's time to be awake or time to be asleep. There are changes that happen also as we age. And this slide, it may be a little busy, but I'm going to walk you through what it's trying to convey. One is just showing that we lose sleep. In general, we lose REM sleep, and we lose deep wave sleep, which is the black box, when we age. In fact, after midlife, we lose about 30 minutes of sleep every 10 years. And that's part of normal aging. But in individuals with dementia, they also have lower levels of deep wave sleep and lower levels of REM sleep. And again, that's just to show you that we need less sleep as we age, and we tend to get less restorative sleep and less REM sleep as we age. And that's normal, but is worsened in individuals living with dementia. So what are the most common sleep disorders? There's 4 of them we're going to go through. The number one most common sleep disorder is insomnia. That means when you have trouble falling asleep or staying asleep. But there are others. One is obstructive sleep apnea. And many individuals living with dementia have never been diagnosed with sleep apnea, but may have it. We have found in our research studies that up to 20% of people living with dementia have sleep apnea and have never been diagnosed with it. So if your loved one is snoring or having periods of holding their breath, or what seems to be holding their breath, it is important for them to get a sleep study done. And I have colleagues that are doing research now, giving individuals with dementia CPAP machines, and finding that they are feeling better because of they had probably some apnea that was not picked up. Another similar sleep disruption is restless leg syndrome. And that's a very common syndrome in people with dementia as well. And in fact, we found that particularly individuals who have a Lewy body dementia, or a dementia that's associated perhaps with a Parkinson's disease, are more likely to have this movement disorder, where their legs or their arms may need to feel like moving them all night long. And it does result in disrupted sleep. So there are some biological factors at play there that may be related and are currently being studied. And the final most common sleep disorder is called circadian rhythm disorder. And this is very common in people with dementia. It usually is how people express it is that they tend to be sleepy a lot in the day. We call that hypersomnia. They're in a very light stage of sleep, but they're not engaged with their environment. As the evening comes on, they may actually get a little restless and agitated. And then during the nighttime, they're actually quite awake, or they have lots of moments of wakening, and they have trouble falling back asleep. So actually, their sleep and wake cycle is flipped, and they tend to do a lot more sleeping in the day than in the night. And this can have varying levels of severity, but it is one of the more difficult ways, symptoms that people with dementia have, and can be very, very challenging to manage, especially when you're trying to care for someone at home. So these are the 4 sleep disorders, and we're going to move into a little bit more detail about each of them next. Insomnia is defined by the inability to fall asleep when you want to go to sleep or to stay asleep. And it often means that when you wake up the next day, you don't feel very refreshed, your memory may be impaired, and certainly you feel a little clumsy. You're not functioning at the level that you'd like to function given the amount of time you spent in bed. Often people report that they wake up too early, that they have poor sleep, it's not very restorative, or it's been very fragmented. Ways of treating insomnia these days often include going to bed a little bit later, perhaps going to bed when you're much more tired so that you fall asleep faster, or waking up a little earlier, setting your clock a little earlier so that following evening you're actually tired when you go to bed. That has helped people, although not individuals with dementia. But if you have insomnia and you're not living with dementia, perhaps setting your clock and restricting your sleep time can actually be a good strategy. Other good strategies for insomnia include learning progressive relaxation techniques, and there are certain forms of cognitive behavior therapy that are very useful for treating insomnia. Unfortunately, for individuals living with dementia, cognitive behavior therapy requires some memory functioning, and it is very difficult for persons with dementia to participate in cognitive behavior therapy, or CBT, and so that often is not the best treatment for them. So that's insomnia. We'll move on to the factors that may contribute to poor sleep that also should be looked at. Many medications can also affect our sleep. Certainly if you're taking lots of medications, they may interact with each other. Health conditions, including COPD or heart disease, may make it difficult to feel like you're getting a good breath when you're laying flat. And so often people with COPD or other forms of lung disease may report trouble sleeping. Individuals who have acid reflux or GERD or hiatal hernias also may have a lot of heartburn at night when they lay down, and also more heartburn during the nighttime, and so that can also interfere with your sleep. Other things include just having a comfortable environment in a room that you're using for sleep, so that your brain associates your bed with sleep and not other, like having the television on in the bedroom. So a blue light exposure, having a TV on in our room or having our computers on too much during the day or in the evening time can disrupt sleep. And finally, the lack of activity during the day, during the sun, and exposure to bright light are also factors that influence sleep. So we encourage people to establish a routine that follows the sun, and we'll get into that in a little bit. The significance of insomnia is that about 2/3 of older adults report having some form of insomnia, and it's definitely not something that your doctor asks you about or your nurse practitioner. It's usually not on your physician's radar, and it may not even be on your radar to bring it to your doctor's attention. However, we know that sleep disturbances are increasingly problematic. It puts you at risk for increased medical conditions. When you're not getting enough sleep, certainly you're more prone to having inflammation and compromised immune system functioning. So you're more at risk to get sick because of having interrupted sleep. Your also not probably functioning at the level that you need to function every day. And you're certainly therefore at risk for safety falls and automobile injuries. And in fact, many automobile injuries have been attributed to poor sleep. So those are things that are all consequences of sleep, and why it's getting a whole lot more attention in the press and in the media as we learn more about it. I wanted to distinguish what normal changes in sleep that are considered normal, distinguish them from the changes in sleep that happen in individuals with dementia. So this is a very busy slide with a lot of words, but I'll just sort of summarize it. One is that as we age, we know that we have less sleep, especially that deep sleep, and a little bit less REM sleep as well. That we do have more frequent arousals and awakenings as our sleep becomes less consolidated, and we tend to need to go to bed earlier and wake earlier. We do tend to follow the sun even more closely as we age, so we often get tired sooner after sunset and want to wake closer to sunrise. We also have increased sensitivity to hormonal changes and environmental conditions, probably because many of us, as we get older, are living with some arthritis. We might have pain. We might be sensitive to light or noises or other things in our environment. Also, our eyes change as we get older. Our lens on our eye gets clouded, and so it's probably not taking in the light, especially if we have cataracts. It's not taking in the light that it should during the day to cue that clock region of our brain. And so there's also some thought that many of the visual changes that we experience as we age might also be related to changes in our sleep. Conversely, in individuals living with dementia, they actually sleep quite a lot in that very early stage 1 sleep. But then they also have longer periods of awakening. So stage 1 sleep is where we see they're getting much more, but again, that doesn't have as much restorative or learning and memory properties as deep wave sleep and REM. And those are the things that decline in older adults with dementia. And so they don't have the really good sleep, efficient sleep, or the deep wave sleep that we would like them to have. Two other common sleep disorders in persons with dementia include sleep apnea and circadian rhythm disorder. So I want to spend a little bit of time on them. As we were talking earlier, you know that sleep apnea is very common, and in about 20 to 30% of people living with dementia are expected to have some form of sleep apnea. Now, they may have had sleep apnea in the past, and it may be why they're experiencing dementia. If we're not getting enough oxygen to our brains over a period of time, that lack of oxygen can cause damage to the brain and may manifest itself as a dementia. So if your loved one is snoring or having temporary loss of breath during sleep, it's important for us to treat that. And it is very treatable these days with a variety of what we call CPAP machines, these high pressure airway machines. Many of them used to be quite claustrophobic feeling. It's a mask that we have to wear. But now they actually are quite they're much more comfortable, much more discreet, and people are finding them very tolerable, and once they get used to wearing it, find it very helpful. So although I want to point out sleep apnea does not directly cause dementia, definitely people who have had sleep apnea typically are at increased risk for dementia, and people living with dementia are have higher rates of sleep apnea than the other parts of the population. So there's an important something happening here that we want to pay attention to and talk to our doctors about. The other common sleep disturbance is circadian rhythm disorder. Again, this is when a person's sleep and wake cycle is kind of flipped. So their sleep patterns happen at not normal times of the day. There's lots of reasons why this could be happening. It could be a result of medications. Often if we're taking diuretics, we might have to get up and go to the bathroom at night, and then perhaps we're sleeping the next day, we take a long nap, longer than we should, and then it sort of begins this spiral of causing a flipped sleep-wake cycle. Another contributing factor for people with dementia is that they might not have enough good activity in their day, something that really engages them, and because they have more apathy and it's more difficult for them to engage in their daily lives or in things that give them meaning in their day, they may doze off just out of boredom and their inability to participate or their sense that they can't participate. And so what is important here is to keep in mind that we want to keep people actively engaged in the daytime and think about activities that we could set them up, physical activities, social activities, long-term memory, perhaps reminiscence activities. Those are things that will engage the person's brain during the day and prevent them from perhaps napping out of boredom. Everyone deserves a nap, and so we're not saying that people shouldn't nap. In fact, in the middle of the day after lunch, many cultures have siestas, and there's a biological reason for that. There is a dip in our hormones, as we were talking about earlier, and so a little brief nap is fine. It just should not exceed an hour. That really is problematic. It's very hard to get aroused after you've been asleep for that long, and often it just throws off your sleep that night. So we want naps perhaps, but not to have them too long. One other cluster of symptoms that happens in people with circadian rhythm disorders is sundowning. And this is a symptom that happens, again, as the sun is setting. People tend to get more agitated. They may be irritable. They may be inconsolable. They may be restless and wandering and tending to increasingly get agitated. This biologically is very similar to what happens to children at around 6 months of age. It's a way of the nervous system sort of expressing the stressors and sensory information that a person's taken in over the day. And for babies at 6 months, it's really their beginning nervous system sort of processing information, and they process it by crying and almost being inconsolable also. They feel like similar brain activity is happening in people with dementia. They've taken in a lot of sensory input in the day, and they're having a very hard time processing it and preparing for sleep or transitioning toward rest and relaxation. Again, some of the strategies that we want to think about for people who have sundowning is to increase their daytime activity, but then introduce a more relaxing environment in the evening, dimming the lights, cooling the temperature down, and thinking of soothing but not stimulating activities at that time. That does seem to help, and many nursing homes, in fact, put certain protocols in place in nursing homes to help with sundowning by changing their lighting in the evening and other activities like that. So we're moving on now to thinking about what we can do about these sleep problems. The first is to talk to your clinician about the challenges that you're dealing with in your own sleep and in your loved one's sleep. That's very important because it's often not something that clinicians are very attentive to. And the second is to implement strategies to improve sleep. So let's talk about first, how do we assess whether or not there are sleep difficulties? Here's a couple questions I would like you to think about. Does your loved one have trouble falling asleep at night? In other words, when they go to bed with the intention to sleep, how long do they lay awake? If it's more than a half an hour, then we definitely want to bring that to the attention of the clinician. Also, after they've gone to bed and perhaps after they've fallen asleep, how many times a night does the person wake up? Another, certainly something you want to let your physician know. Many people have to get up once or twice during the night to use the bathroom. If they do, we want to make sure that the lighting in the environment is not overly bright. So we want to have night lights on, but if we introduce bright lights at this time when people get up to go to the bathroom, it can often trigger the brain that it's time to be awake. So there are newer light bulbs in the market now that are better at keeping it safely lit, but not overly lit. And that's the thin line we're trying to tread here. Second is whether or not your bed partner is snoring or gasping for air or having periods of where they're not breathing during the night. This would certainly indicate sleep apnea or potentially sleep apnea. And nowadays, we're actually much better at doing sleep studies, where we used to have to go to sleep labs and spend the night really not sleeping well. Now, more sleep studies, in fact, most sleep studies are reimbursed in the home setting finally they're realizing that that's a better place to assess how well someone is sleeping. And so we have found that people with dementia actually can tolerate sleep studies in the home without too much trouble. The devices they're using now are not as invasive. Not that they're not too invasive, but it's easier for you to get a sleep study done at home. The third is, of course, if your loved one is sleepy or tired during much of the day, and whether or not they're having trouble engaging in activities and they look like they're napping or really just almost tuned out from their environment. This could mean that they're getting a lot of that stage 1 sleep, and it's a consequence for the respective night that they're going to have trouble falling asleep. And then whether or not they take a nap during the day, you do not want them to nap longer than an hour. Up to an hour is fine, generally about a half an hour to 40 minutes is a rule of thumb for napping. So we want to set clocks and then have some physical activity after the nap to help people get aroused and be able to be alert. So this is probably the most important slide, and this is my last slide, and then we'll move on to questions. We're going to go through some of the strategies for improving sleep. Routine is probably the most important thing for individuals living with dementia. A very predictable routine schedule where the same things are happening at the same time each day. And by the same things, I mean activities of daily living. So we want to have the same wake time, the same breakfast, lunch, and dinner time. Meals are something that also trains our brain to daily activity. We want to increase bright light exposure. Certainly we want to follow the sun and where possible, get some bright light exposure every day. And in fact, some research has shown that in people living with dementia, when they have had bright light exposure in the morning time, they actually sleep better that night. There are bright light boxes on the market. These are these are for people who might suffer from seasonal affective disorder or live in parts of the world where they're not getting enough daylight. They use natural light boxes to make sure that they're getting enough bright light exposure. The challenge is that you have to sit in front of the box for the period of time, generally 20 minutes or more. And for some people with dementia, it's a little challenging to do. But any kind of bright light, and many of the Philips light bulbs that are on the market these days and other vendors do have nice UV light exposure in their light bulbs, and so you can mimic bright light exposure. Of course, the best bright light would be the sun itself, and so making sure that your shades are up and the bright light is coming in your home is probably the best way to improve that. And again, morning time bright light exposure is really great if possible. The other is to have some form of physical activity. Again, research studies have been done that have shown that when older adults have people living with dementia have about 15 minutes of physical activity or more a day in chunks of time throughout the day. And it can be exercise, but it doesn't have to be. It could be social walks. It could be other activities, balloon tosses, other things that help get your heart going and are fun to do. But adding that into the day is very important. And often the afternoon is the best time. Even after that nap is a good time to try to get people to do that. The reason being is that our body temperature is a little warmer in the afternoon. In the morning, if we try to exercise and our body's still cold, it can make us more prone to injury. But any time you can get someone to do physical activity is good. Finally, the next is around a relaxing bedtime routine. This could involve warm milk or other cues, having a routine that is predictable around bedtime so that we can help the older adult with dementia understand and train their brain to associating that routine with getting sleepy and going to bed. That means having a comfortable, quiet, and dark, and preferably cool, physical and comfortable bedroom and our sleeping quarters. We can, if a person is taking diuretics, we can time the diuretic to be earlier in the day if it's a reason that they're getting up at night. We can also curb fluids, especially things like caffeine, but a lot of fluids in the evening might also cause us to get up at night. Not that we want to discourage fluids, they're important, but we can certainly give fluids earlier in the day. And also, if the person has had heartburn or any indigestion, you don't want to eat too close to bedtime or then lay down too close to your mealtime because that can also result in some challenges for heartburn. And stimulants, including caffeine, we want to keep to the morning time. Nicotine is also a stimulant, so we want to restrict that. And alcohol. While some people feel like it can have some sedating properties, it also has diuretic properties and it does interfere with sleep. You don't actually get good deep wave sleep when you've been drinking alcohol. So while you do get sleepy, it's not the good kind of sleep that you need. So that's our summary of our suggestions for you. We'll now open up to questions.
Thank you so much. That was wonderful. We do have a first question. I'm curious about the statement that persons living with dementia typically sleep less. Is this true for all stages of dementia? Does required needed vary as the disease progresses? Example, from early, middle to late stages.
So the sleep that people with dementia are getting less of is that deep wave sleep. They do spend more time actually sleeping in stage 1 sleep. So it's not that they're getting less sleep, they're just getting less of the good kind of sleep, less REM sleep and less deep wave sleep. And yes, that does worsen as the disease progresses. So as individuals move into the very advanced stages of sleep, they're certainly sleeping a lot of the time, but they're not getting deep wave sleep and they're not getting REM sleep. They're spending a lot of time in that stage 1 and 2 sleep.
Thank you. Is it okay for people with dementia to take Ambien? What is the best sleeping medication?
Okay, that's a really great question. Ambien is not a good drug for helping people with dementia. There's lots of research that has shown that any of these type of psychoactive medications actually have higher morbidity and mortality associated with them. In other words, people tend to, when they take these medications, actually not be getting the good sleep that they need, and they are increased risk for falls, increased risk for more memory problems. So we do not encourage the use of Ambien in people with dementia. What we do encourage is the use of melatonin. If there's any agent out there that has been shown to have some good pharmacologic properties, it's melatonin. And 2 milligram doses are what are suggested. So very little doses. In fact, when you go to the supermarket and you see melatonin, often you see it in 5 and 10 milligrams. That's a little too much. It's better to start low. It actually works just as well as higher doses. You just want to make sure you talk to your pharmacist about a reputable company so that you are getting the 2 milligrams because, again, these are over-the-counter agents. There is some suggestion that trazodone, which is an old-school antidepressant, has shown some effects in sleep in people with dementia, but it does have to be taken carefully because, again, it's a psychoactive agent and it has its own set of side effects that go along with it. But that's the only other medication that really has been shown to work in individuals with dementia.
Thank you. We have quite a few questions, so hopefully we'll be able to get through them all of it a little bit after 2. Is that okay with your schedule?
Of course.
Okay, so we have another question. My father, 86 years old, has always been a terrible snorer, and his siblings have sleep apnea. His dementia has been very rapid onset for the past 6 months, and I've wondered if his sleep breathing could be part of the cause.
I suspect it could be, and I would really highly encourage him to get a sleep study done, especially what's concerning to me, as you said, it's very rapidly progressive. And dementia in and of itself is often a very slowly progressive condition. So I would highly encourage your dad to get a sleep study done, especially as you said, it runs in the family. And he may really find that a CPAP machine will make him feel a lot better and stave off some of the memory problems.
Thank you. Another question is, my mom is deaf, age 93. That complicates everything. Any thoughts?
Yeah, certainly individuals with hearing problems or vision problems are at increased risk for sleep issues. because again, especially if they have dementia, it's only further complicating the sensory input and the way the brain is interpreting the sensory input. And we rely a lot on sound to help cue us to environment. So if we're living in silence all the time, it can be very difficult. There are ways of visually cueing the environment enhancing different visual cues, signs, or other things that we can use to help orient her to her environment and engage her in her environment, so that she feels like she's participating in something every day that gives her meaning, and so that she's fatigued by the evening time, and can sleep. But I agree it is challenging. I find that occupational therapists are very useful to speak with about coming up with a plan of activities for loved ones. So if you can speak to your doctor for an occupational therapy referral, that may be helpful.
Thank you. I've noticed my father will wake early and go downstairs to watch television. Do you have any strategies to limit television watching?
I guess it's probably a routine that he's used to, I would guess, and so it is challenging to break someone's routine. The best way to do that is to substitute TV with something else. So it depends on how you want to go about that. If there's perhaps music he could be listening to or something else that could engage him, that would be my suggestion. But again, it is hard when people have patterns that they have that it is hard to break that. So it's about being creative, I guess, and trying to come up with other strategies. Again, it's hard to say with not being in your home to come up with other things that we could get them to do in the environment.
Thank you. Any strategy for helping someone with dementia get back to sleep after they've awakened because of a hallucination? Example, they may believe they smell or hear something that's truly not there.
Yeah. Well, what not to do is not to argue with them, because they really do believe that sound or smell or thing is there. And so it's really seeking, what they're expressing is fear, and what they need is reassurance and distraction. So often people can be, not easily, but they can eventually be redirected and distracted to something else. And it's just a matter of finding something else that works. Sometimes a quiet music or quiet sounds can be a distraction. It can replace the sounds that they're hearing that are concerning to them. There can be sometimes gentle touch, and just your presence can be reassuring, and using a very reassuring voice can soothe someone, but not arguing with them that the hallucination is not real, because that just makes it worse.
Thank you. I have a special needs sister who at one time was on a CPAP machine for sleeping issues, but was taken off of it, and the last 6 months or so we have noticed a difference in attitude and behavior and sleeping throughout the day. Do you think being off this machine is a cause for the different behaviors?
I really do. I'm concerned, that she was taken off that machine, and I think it's probably worthwhile to have her reevaluated. It's very curious that right after she was taken off that machine, you noticed these changes. So, and certainly the changes you're describing make me think that she's not getting good sleep at night, and therefore she's very tired in the day. And the CPAP is designed to help her sleep at night. So I would encourage her to reconsider. Again, there are so many updates in these sleep PAP machines that if it had to do with her not tolerating that machine well, there are newer devices on the market that many people are finding more useful.
How do you feel about giving Alzheimer's patients Risperdal?
Well, I would wonder, what was the rationale for that medication. I think we have to make decisions very carefully when we're using things like Risperdal, and consider the side effects. It's very hard to comment individually on one case and medications, because there's probably so many other factors at play. So I'm sorry that I can't comment more specifically on that. In general, we do try not to use any kind of agents like that because of the side effects associated with them.
Thank you. How effective is a tongue retaining device in regards to sleep apnea?
If the person has had a sleep study done and it's indicated that it's actually their tongue that's falling back over their larynx, and that's why they're having the sleep apnea because of they have perhaps a large tongue, then those devices are useful. In fact, they're just as useful as a CPAP machine. So yeah, they can be useful. It's just making sure that is determined to be the cause. So you'd want to have an evaluation to make sure that is the reason.
Thank you. We'll wait for other questions to trickle in.
Okay.
Yeah, we have some really good questions. Thank you, everyone, for.
Yeah, really great.
Yeah, very great. So let's just wait, see if anyone else has any other questions or comments that they'd like to ask. Okay, let's see. Okay, how soon before bedtime would you suggest the limiting of fluids?
Generally, we say not after 7 p.m., but it does vary based on when a person's going to bed. So typically, it would be 2 to 3 hours before bedtime we'd want to restrict fluids.
Thank you. Is it possible for someone living with dementia to experience sundowning and not have circadian rhythm disorder?
Yeah, in fact, that's a really great question. Circadian rhythm disorders can manifest differently, and sundowning is just one way a person can express circadian rhythm disorder. If circadian rhythm disorder is the umbrella, sundowning is just one small thing that can happen under that umbrella, and often that sundowning will continue to be a problem and may lead to other circadian rhythm problems, but it's just one example of one.
Thank you. I can imagine that sleep studies are a stressful process for patients with dementia. Are there any institutions that specialize in this patient population?
Yeah, there are many academic medical centers that are and in fact we do so here at the University of Penn. We have sleep studies specifically for people living with dementia. We do them in the home, and we have technologists that come in and set the person up that have some familiarity of working with people with dementia. But we are not the only academic medical center in the country that does so. So depending on where you live in the country, it's good to look at, you want to look for major medical centers that are affiliated with universities, because their sleep centers probably have different specialists on hand to handle the challenges. As you mentioned, it can be quite stressful to have someone come in and put a band on your head and some chest, some stickers on your chest to measure your EKG. There's other things that are needed as part of a sleep study. We put other stickers on your arms to see if your arms and legs are moving. But usually those technologists can set you up in a way that is tolerable for the person. And if we're mostly interested in just sleep apnea and not in restless leg syndrome, we probably don't need to put the stickers and leads on arms and legs. We may just need to have it. We may just need to have like a chest sensor to see whether or not they're having pauses in their breathing, and an oxygen sensor on their finger. So we've done sleep studies with just a very simple clip-on pulse ox on the finger and a very small chest sleeve for heart rate, and that's been enough to measure sleep apnea. So lots of options that are available to make it easier.
Thank you. Okay. My husband has early onset, young onset vascular dementia who sleeps several hours throughout the day, as well as sleeps throughout the entire night, perhaps 12 hours. If he does not get this amount of sleep, he is easily angered, agitated, and confused. You recommend a person sleep only 1 hour a day. Do you think I should try to limit his daytime sleep? He does have sleep apnea and faithfully uses his machine.
That's a really great question. In your husband's case, I would say that the way you described it, that he seems to need those long hours of sleep in order to feel that he can tolerate his environment and not get too stressed, I don't know if restricting sleep would be a good idea. So my comments earlier were very general in nature and not really meant to be specific. And I think, given that your husband sounds like he needs those sleep hours, I wouldn't change it. Unless you're concerned about something else. But I hope that your physician is aware of the amount of time that he's sleeping, and is sensitive to that. And so that certainly he's been evaluated for that.
Okay, thank you. What is the treatment for restless leg syndrome?
There is pharmacologic treatment options available, and you probably have seen them, or perhaps you've seen them on the television. So we do notice that individuals with restless leg syndrome do seem to have certainly have changes in the brain and to certain neurotransmitters that are much more active. And so the medications these are psychoactive agents. They're serious medications, but they do seem to work in helping the what we call motor problems and restlessness that happens.
Thank you. Hold on. I know from experience that music does amazing things for those living with dementia with help awakening their brain. I know my mother would listen to music before bed, but if a person with dementia listens to music before bed, are they less likely to fall asleep or have more meaningful sleep?
That is an excellent question, and in fact, we have a research study right now that we're doing to look at the properties of music that help induce sleep versus music that's meant to stimulate you. So music, if you think about the different properties in terms of the tone and the beat, have different ways of stimulating us. So in the daytime, we may want to have, if we're trying to exercise, for example, we may want to have a beat that's a bit more rapid. Perhaps a beat of like 80 beats per minute. In the evening time, though, we can have music that is actually perhaps less than 60 beats per minute, and those beats actually cue our heart rate, so we can actually change our heart rate based on the beats per minute in music. And a slower beat per minute music can mean that our heart rate goes down and we feel more relaxed. Deeper tones, so particularly delta waves in music, also are very useful in inducing sleep. And you can go online and actually Google delta wave music for sleep. And it's a very deep tonal, very slow beat music that people use for insomnia. And some people have found it very useful. Also, we suggest in the evening time for sleep that you don't want to play familiar music, because obviously that gets you excited. When it's something that you're used to and hearing, you can actually, it makes you more alert. So sleep in the evening time, we like some classical music can be useful, but usually it's a very unfamiliar, very relaxing, almost like what you hear when you go in a spa kind of music that does help people fall asleep. So it has I agree, music is really interesting in terms of how it can, and just how it can really engage people with dementia, especially long-term familiar music. It really is very meaningful for people.
Thank you. We have a comment that one of the listeners, she said, I have designed a sleep readiness program for a dementia unit encompassing all the areas you touched on. I have educated the staff, nurses, and doctors, but they don't buy it. Using instead medications, TV in the middle of the night help.
Yeah, it is. I mean, I think sometimes we go to the magic pill. We look for some sort of, magic pill. It's easier than sometimes introducing these behavioral interventions. It takes more staff time to do them. But if you were to show them the research, there's certainly the American Academy of Sleep has put out that these medications to improve sleep have worse outcomes for people with dementia. And that these behavioral interventions that we've just talked about, exercise and light exposure in particular, and combinations of that, there's a number of publications, and I can send that, and we could post it here, that really show and perhaps you'd want to show the evidence, the very strong evidence that supports your program.
Thank you. My 93-year-old dad has dementia. We are not sure which type exactly. Doesn't matter. He is physically very agile still, but has sundowning and late night wake-ups that last for hours. Any thoughts? He does take trazodone.
Okay. Well, it's good to hear that he's getting some attention to his sleep problem. Your first question around what type of dementia, you're right, it really doesn't matter. In fact, we realize more and more that most people living with dementia probably have a mixed dementia. They may have some Alzheimer's, but also some vascular dementia. When we look at, they may have some Lewy bodies as well. So we are really not as focused. It is important to, I think, understand perhaps the type of dementia the person has. If they have frontotemporal dementia, that can result in other behavioral challenges, perhaps, that would be important to know. But overall, what we're talking about here and the suggestions work for any type of dementia. So they're not specific to one type and are helpful to all people. So the second part of your question was around other strategies to introduce, especially during his wakefulness at night. And I think perhaps if we can introduce more activities in the day and make sure that when he does go to bed at night to sleep, that he's tired, that he's going to bed at the right time. So when he does fall asleep, he stays asleep. Some of the other things around bright light exposure or limiting that exposure at night would also probably be helpful to him, because introducing television watching in the middle of the night, the blue light from the TV is probably confusing his brain. So like the earlier question around restricting TV use, it's finding something else to substitute for that. Could be listening to music, as we just talked about, or other activities like that don't have the blue light associated with it.
Thank you. I have a general question. Do you have any suggestions for doctors? I'm not sure exactly what that implies, but I think it's just a general question for the individual living with this disease going to their doctor.
Yeah. Well, I think we would hope that doctors are aware of the evidence out there around these different strategies and are able to teach people or give people information on these strategies, just even a simple handout of how to establish a good routine, how to limit caffeine intake, good sleep hygiene practices. We would hope that doctors could have that information to give their clients. And I think there is information online that's helpful to people, but it's just a matter of getting it into doctors' offices. And then around melatonin, I think hopefully physicians are comfortable understanding that even over-the-counter agents are as effective sometimes as prescribed medications. And in fact, in this case, for dementia specifically, low-dose melatonin has been shown in the science to be one of the more effective agents than compared to anything else.
Well, thank you so much. We are approaching the end of today's presentation. We'll wait another moment to see if we have any other questions trickle in. If not, while we're waiting, I want to welcome everyone back to our Care Connection for June 14th. The topic is going to be bringing oral care to dementia care from 1 to 2 p.m. Eastern Time. And I want to take the time now to say thank you for today's wonderful presentation. I certainly learned a lot of new information that I will trickle down to those I serve, and a lot of positive feedback. Dr. Hodgson, you made it very accessible and a lot of great feedback. A lot of people enjoyed today's presentation, and we're very thankful that you were able to share it in such a way that you did. So a lot of people are singing your praises, as I am too. We thank you for your volunteering your time and expertise and taking time out of your day to answer our questions as well.
Oh, sure. Well, thank you for the excellent questions, and thank you so much for this opportunity.
All right, then. The the thank yous are, they keep trickling in. So I want to thank everyone too for taking time out of their day to listen to today's presentation. And again, I want to welcome everyone back for June 14th presentation on bringing oral care to dementia care. I hope everyone has a wonderful rest of the day and a good week. And again, thank you to our presenter. We had a great time today. I hope everyone has a wonderful rest of the day.
Take care, all.
Bye.